Welcome to Fertility and Sterility on Air, the podcast where you can stay current on the latest global research in the field of reproductive medicine. This podcast brings you an overview of this month's journal, in-depth discussion with authors, and other special features. F&S On Air is brought to you by the Fertility and Sterility family of journals in conjunction with the American Society for Reproductive Medicine.
Hi all, welcome to F&S Unplugged. So Pietro is on a well-deserved vacation this week, so the quad pod is down to a tripod today, and I'm filling in on the Iron Throne today to host this month's episode. So Dalen and Blake, it's so nice to see you both, and glad to see Blake back from his vacation. How have you guys been?
Doing very well. Very happy to be back after not being here last month. I was sad to miss you guys. And also, Molly, did you say y'all? That's very Oklahoma of you.
I don't think I said y'all. I'm from Massachusetts.
Well, I that's why I found it strange. So I just wanted to ask you about that. But nonetheless, very happy to be here and see you all, and looking forward to having Pietro back next month.
I second that, and I will also second the y'all. There was a y'all there. I don't want to have to go to the tape, but
there was y'all. I'm from Oklahoma. Right. I know a y'all when I hear it.
All the y'alls have been on vacation. I think it's about time for me to take a break. So don't expect to see me next month.
They're going missing. Okay, sounds great. So I thought there is kind of a common theme between Dalen's article and my article today. So I thought we'd just start with Blake's article first. So take it away, Blake.
Thanks, Molly. The title of the paper I'm going to be reviewing is called Biomarkers to Predict Improvement of Sperm Parameters and Hypogonadism After Varicocele Repair by first author Alexandra Varnum and senior author Ranjith Ramasamy out of University of Miami. A little bit of background. As we know, male infertility is responsible for about 20% of cases of infertility, but may play a role in conjunction with female infertility in as many as 30 to 40% of cases. Of the numerous potential causes of male infertility, varicocele is the most common and is the most common correctable, according to the authors. As a result of impaired venous outflow from dilated veins in the scrotum, varicocele is known to lead to testicular atrophy, impaired spermatogenesis, hypogonadism, and impaired sperm motility, which is not ideal if you are trying to conceive. Studies suggest that approximately 40% of men with primary infertility and as high as 80% with secondary infertility have a varicocele, making it the most common correctable cause of infertility. I was extremely surprised by how prevalent it was with 80%. That was very high. So, although there are several hypotheses for the mechanism by which a varicocele may cause symptoms of infertility or pain or hypogonadism, many patients with a varicocele largely remain asymptomatic, and it remains unclear why only a small subset of men with varicocele develop symptomatic pathology. So this study examines a range of markers, including proteins, RNA, DNA, as well as metabolites. More specifically, they look at proteins implicated, such as heat shock proteins, proteins involved in oxidative stress, mitochondrial function, including some known as HSPA2, APOA2. There are a huge list. There's literally hundreds and hundreds of proteins that they list throughout this study that are random combinations of letters and numbers. So I'm not going to go over all of them for obvious reasons because it would just confuse myself and you all too. But they go over a lot of them in the study. So several of these have been investigated within the context of varicocele when they compare to their expression in healthy men. Now, obviously, it would be really nice to be able to obtain non-invasive biomarkers to predict an improvement in fertility, a response to varicocelectomy, and minimize having to undergo the surgeries in order to optimize patient outcomes. So this review consolidates the current knowledge, existing gaps, and outlines future research at directions to seek a refined diagnostic and therapeutic strategy for varicocele-related infertility. So I'm going to dial it in. Dialing it in with these review articles can be quite difficult. So bear with me. There's literally 109 references in this article. So I'm going to dial it down, summarize the main findings here. So although many patients will experience improved sperm parameters after varicocelectomy, not all men will. The authors, they quote that approximately the number needed to treat for varicocele repair in order to obtain one additional pregnancy is 7. So 7 varicocelectomies for one additional pregnancy. So therefore, it's poorly understood which patients are in fact optimal candidates that will benefit this surgery. Obviously, this is a surgery that's not exciting to have to undergo. When you're talking to a patient about doing this surgery, you better have a pretty darn good outcome or reason to undergo this surgery. And so being able to convince patients that this will help improve their outcomes is certainly worthwhile. So the authors discussed that many proteins implicated in oxidative stress pathways have shown differential expression in infertile men with varicocele versus healthy men. Some studies show that these antioxidant proteins are upregulated, such as one called PRDX2 in the seminal plasma in varicocele repair patients. So they also talk about heat shock proteins. So these proteins play a protective role in cells that are undergoing stress and allow cells to survive in potentially lethal conditions such as increased temperature. Obviously, you have the venous outflow is not optimized in a varicocele, and so you have venous stasis, increased temperature, and then you had dysregulation of spermatogenesis, and these heat shock proteins are not able to function as well as they normally would. Prior studies from Hussein Afar, I'm probably mispronouncing that, but they found that there's lower expression of heat shock proteins in spermatozoa of men with a varicocele. And they attributed this to impaired protective mechanism against stress such as heat from a varicocele. There's also some studies that showed that they do a varicocelectomy and the expression of these heat shock proteins are increased afterwards. So the authors also discuss several proteins involved in oxidative stress, and these are notably downregulated in the studies that they look at. So these proteins normally involved in energy metabolism. They specifically looked at 22 different proteins discussed, and their findings show that, as I mentioned earlier, there actually were as many as 370 proteins that they looked at in total, so tons of different proteins. But they looked at some patients with a bilateral varicocele, some patients with a unilateral varicocele, some patients who have these proteins before a varicocelectomy and then afterwards. And there's many different findings, basically, is the summary. Some of them are upregulated before, some are downregulated after, some are downregulated before, some are upregulated afterwards. So there's obviously something there. There's a proof of a concept or a proof of point there. But there's a lot to still look into with this, a lot of further additional research that needs to be done in regards to this. But the authors discuss post-translational modifications to a lot of these proteins is what they think plays a significant role in altering protein structure, function, and expression. So this makes sense, right? And because these are altered, therefore it can affect the sperm function or the sperm parameters. There are only a few studies that have evaluated the biomarkers after varicocele repair. But obviously, again, the authors discuss a need for this to be increased in the future. So there was also an additional study where they look at DNA damage. This can result in apoptosis, diminished sperm function and motility, and they found that several of these markers were repaired or improved after varicocele repair. While proteins are the most widely studied marker for this, the authors do describe that there are a few studies which RNA and DNA, so most notably DNA fragmentation, which I know we've talked about quite a bit in the past for various things on our podcast, but the authors talk about DNA fragmentation as biomarkers of varicocele presence are certainly something that have been shown to be altered initially, then after varicocele repair have improved. And then lastly, the authors discuss varicocele-induced damage to the Leydig cells, which we know produce testosterone in the testicles, and this can result in lower testosterone production and therefore hypogonadism. And so they note that some, not all studies show that by doing a varicocelectomy, it's going to improve that venous stasis, decrease the damage that's done to the Leydig cells, and improve function of the testosterone production. And this is found at the 6-month follow-up in a lot of these patients that they have improved testosterone production as well as sperm parameters have improved. All right. So in conclusion, I think my podcast hosts are falling asleep on me here. Sorry, guys. I'm trying to dial it in. It's a big paper. In conclusion, they discuss that while varicocele has been identified as the most common correctable cause for infertility, the diverse symptomatic expression remains unclear. and the predictability of improvements in sperm count and fertility post-repair is still not consistent. So a lot of research still needs to be done. This huge review, as I mentioned, over 100 references, explores the potential use of biomarkers, most notably protein markers, but also looked at RNA and DNA, as well as metabolites, and how it relates to improvements of sperm parameters following repair of a varicocele. There's still a growing interest in a lot of these biomarkers, but the main aim of this is to find a non-invasive way to help evaluate these men, who would be a good candidate for surgery, and how did the surgery help improve these biomarkers as well. So I'm going to let you guys talk because I've been talking a lot for the past several minutes. So hopefully you guys are still hanging there with me. But what do you guys think about this study? I mean, obviously, a lot to be done. This is something we see very commonly. Obviously, a lot of men have it. But what were your thoughts on this study?
First, I want to say, falling asleep? No, overstimulated here. 100 and something biomarkers is just a feast for the imagination. But I will say, whenever I see these biomarker stories, what I'm always searching for, and of course, in this case, and in most cases, is not really there. And that's not to take away from it. I mean, a lot of medicine historically has been, you make decisions based on correlations without really any defined causality or mechanism or anything. But still, for me, when I hear biomarkers, I have like the second thought is like, okay, how is that marker linked to the disease? Like take, for example, C-reactive protein in the case of systemic inflammation, or cardiac troponin for myocardial infarction, even like LDL, HDL, right? In terms of prediction of risk, all the things that I'm really comfortable with, just because they make sense for me, are the ones where it's like, okay, this is a marker because, in the case of MI, for example, it's like a insult injury in the heart, and you're getting all this cardiac troponin, which is, from the cardiac myocytes dying, essentially flooding into the system. Like, okay, that makes sense. I get it. And I wouldn't say it's my problem, but my frustration with all these biomarker studies is that, yes, some really fine candidates emerge by these kind of unbiased analyses and comparisons between control and patient group cohorts, whatever. But then it's kind of like the next study you read, they'll identify another few biomarkers and then another one. And then in aggregate, you read this review and there's like tens or hundreds of candidates, and the link, the causality or whatever, the intuitive understanding of it is lost to me. So I don't know that there's anything to be done for that, but I do wish there was more of an appetite for just taking one of these, or this review, for example, and I'm not going to do it. So I'm not expecting anyone else or asking us to do it, but to like systematically take one or a few of them and try to flesh out, either in a larger population or look deep into the biology of that protein or whatever biomarker, and try and make some sense or put the puzzle together as to how that observation is related to the disease that or condition that you're concerned about. And again, it's a high bar, but I'm waiting for the paper that takes all these biomarkers and makes them make sense to me.
Yeah, I almost wonder if they could all be compiled into like a risk score, which I know we tried that for like adnexal masses. It never quite took off, but mixing everything together, really big credit to the authors. It's so comprehensive. I'm bummed that we don't have a better answer from this, but it's a great starting point. And then it has a table. This one has a table, but it's not one that we can print out and put on our desk and use clinically just yet. But I do think like a very astute andrology fellow looking for a project could definitely use this table to kind of decide what their next basic science or translational project would be. So thank you, Blake.
Yeah. And then maybe one day when we know more about these biomarkers, I kind of am sensing a nice heat map that we can form from this. I love a good heat map. So I'm just going to throw that out there. If someone does it in the future, you can take that idea and run with it.
Evan has a computer program to do the heat mapping, so just call him up.
That's right.
Okay, great. So I'm gonna hit the ball over to Daylon next. So the commonality between our two papers is going to be the patient experience and really emphasizing that. So take it away, Daylon.
Yeah. I mean, you might have thought by what I just said that I'm all about like the hard science, objective, give me the mechanism, blah, blah, boring. I want to hear about people's feelings. That's what I'm into these days. And this is a story that's well aligned with that desire. I got my wish. What we're talking about is controlled ovarian hyperstimulation, a mainstay of assisted reproductive technologies and IVF. It's become so commonplace that it's considered routine, and greater access, declining fertility, as well as the kind of social impetus behind ART nowadays, like oocyte cryopreservation specifically, in the context of delayed childbearing. All these factors are all increasing the scope of ovarian hyperstimulation, and the efficiency has increased incrementally over the years. Protocols have been diversified to meet a whole variety and breadth of patient needs. But the basic mechanism and more the timing of ovarian stimulation has been pegged to the natural timing of follicular growth, maturation, and ovulation, right? We're not going to make these eggs develop any faster. I mean, maybe somebody is, but so far we haven't got there. And what that means is a week or 2 weeks, somewhere in there, of ovarian stimulation. And while this is routine, as I said, it's also tremendously disruptive. You got the regular venipuncture, daily in some cases, to monitor serum values, and a broad range of misery-inducing side effects that I really can't identify with at all, but I recognize. Also, not to mention the actual significant risk of ovarian hyperstimulation syndrome and all the sequelae there. So it's a big deal. Ovarian hyperstimulation, while routine, is also disruptive. And while the most recent season of Serial, I don't know if you guys caught that, but any REI or anyone with an interest probably should have a listen. The recent season of Serial really highlighted this frightening debacle at Yale. Sorry to call you out, Yale, but you're going to be just fine. It drew a lot of attention to the trauma of oocyte retrieval, and I was really compelling and upsetting, frankly. And not just with these women who didn't get the drug. The story was they weren't getting the drugs, were being stolen. They were being given saline. But even with drugs, a lot of patients report the trauma there of retrieval, which has been highlighted. But I wonder if we don't talk enough about the trauma of ovarian hyperstimulation. I mean, you guys tell me, do you ever get feedback from patients? I know that there's a lot been said, as I just alluded to, about the trauma of retrieval, but do you ever get patients who are like, I just can't do it, doc? I mean, the getting my blood drawn every day, I have a phobia, whatever it is, or the side effects, I just can't do it. I'd rather not have a kid. Do you ever get feedback that really harps on the trauma of the ovarian hyperstimulation?
I wouldn't say trauma. I mean, I feel like that's maybe a strong word. We do, certainly these patients, they're uncomfortable. Their ovaries are enlarged, they're bloating, and a lot of visits, a lot of ultrasounds, a lot of blood draws. Not fun by any stretch of the imagination, but I've never would say it's traumatizing to them. And none of them, it's very rare for someone to be like, I would rather not have a child than do that. Patients are very determined and very strong-willed they'll do whatever it takes, So that's just my 2 cents in response to that question.
Blake, you made a really good point there. I'm not surprised at all to hear that, because the patients power through, right? Because they're highly motivated. It's a highly motivated patient population, and motivation equals compliance. And as you said, these people want to start their family or want to grow their family. But the landscape is changing a bit. There's a growing segment of the patient population that's seeking oocyte cryo as a means to safeguard fertility as they delay childbearing, as I said in the open, right? Maybe not as highly motivated a cohort, right? And this is also like the Amazon Prime era, right? Where consumers expect a quick turnaround, minimal convenience, drop it at my door. I don't even want to see your face. Just drop it at my door. So while you may roll your eyes when a patient asks whether they can squeeze in a quick and tidy cycle of ovarian stimulation and retrieval over a long weekend, say, for example, yeah, you're rolling your eyes. But some scientists and physicians are trying to actually meet that expectation. Among the leaders in this effort is Gamito. I don't know if I said that right. I don't know how else you would say it, but Gamito, it's a biotech that was founded out of the lab of George Church and based on the central innovation of ovarian somatic cells, so non-oocytes, ovarian somatic cells that are generated from pluripotent stem cells, right? And the scientific foundation there is pretty deep. I'm not going to go into it, but putting it really simply, one of the major applications of the work is that these ovarian somatic cells could serve as a supportive substrate for improving the in vitro maturation of oocytes that are that you go oocyte pickup before they're mature, pre-ovulatory. And the real, upshot there is that ovarian stimulation can be abbreviated from between a week to 2 weeks, 9 to 14 days, to 2 to 4 days, so a long weekend. And while the demonstration of improved in vitro maturation in the context of this abbreviated stimulation cycle has been described in a separate paper that was in Human Reproduction just this past fall, the paper that I'm sharing today from Fertility and Sterility Science, it's from the group of Christian Kram, who's the chief scientific officer, also an author on that HR paper that I just alluded to. He's the CSO at Gamito. Maybe that's how you say it, Gamito. Who he led a study aimed at determining whether abbreviated stimulation actually translated to a better experience for the patient. So it's a feels paper. How did the patients like it? And of course, they liked the abbreviated timing, right? But what about everything else? So the design was these patients underwent 3 to 4 days of FSH followed by HCG trigger versus a control group that underwent conventional stimulation over between 8 and 12 days, as it was specified, and had about 2 to 4 times the cumulative dose of FSH and had a GnRH trigger. Not surprisingly, it seemed like patients in the abbreviated group experienced less side effects during stimulation, that being breast swelling, pelvic or abdominal pain, nausea or vomiting, bleeding. Although I should say here, I couldn't find, and I don't think there was, a comparison to the control values in these tables. So it wasn't like the conventional stim patients reported this much and the abbreviated stim reported this much. It was just the values for the abbreviated stim, but those were really positive, like really few patients that reported these adverse side effects. And there was a comparison to the conventional group when talking about pain level after oocyte pickup. And again, as you would imagine, a lot more patients reported no pain. So there were 4 groups, no pain at all, some mild, moderate, and then severe. The dovetailed by the borders being a no pain on the one end and severe pain on the other. And of course, there were more patients reporting no pain, as well as less patients reporting severe pain in the abbreviated STIM group. So it makes sense intuitively. Looks like they had a better experience, particularly at the end stage when, as you described there, Blake, these patients, their ovaries are, really, they're bloated, their ovaries are huge. So maybe at the apex there of that stimulation cycle is a little bit more pain to be experienced during the pickup. Finally, there was this reporting on the patient satisfaction. And again, I couldn't find the comparison and only focused on the abbreviated STIM group here, but 85% of them said they were that was the best rating they could get, very satisfied, and 85% of them said they were very satisfied. To be honest, I highlighted this paper for its constituent role, I would say, in making the case for abbreviated ovarian STIM and in vitro maturation. I think it makes a good case for the feels there, how the patients are going to perceive and react to this. And I think there's a clear benefit there that, just makes sense intuitively. Whether or not this approach is going to be appropriate for this massive market that I think is the target here, those being patients undergoing oocyte cryopreservation for social reasons, I think that remains to be seen whether it's going to be appropriate for that huge market. And it may be worth mentioning that Gamito has raised a ton of money. And I think the investor expectation is that there's going to be a major market share, and this is going to be tech that's going to really disrupt assisted reproductive technologies. We're not talking about a orphan population here. We're talking about targeting women who undergo ovarian hyperstimulation, full stop. So I'm not sure that we're gonna get there and meet the expectations of the investors, but I still think that this is a really important technology and approach for a lot of patients out there, probably more than you think, that might not just have a better subjective experience, but by necessity need to undergo these abbreviated stimulation cycles. So I think an exciting representative example of how the cell-based tech and just tech in general is really moving the clinical practice. And I invite you guys to weigh in on how you think this is going to play amongst patients.
Certainly have some questions about just going through this and hearing you go over it as well. I feel like I have more questions than reassurance, I guess I should say. I mean, of course, we always want the patient's best interest. We want to make sure that we're doing everything we can to where they're not having bad side effects and it's a pleasant experience. But also, I feel like the more or the better way to find this answer are patients who have done the minimal stimulation and also conventional ovarian stimulation, because otherwise it's hard to compare. For one, aside from pain, as you'd mentioned, these other parameters, they don't really compare to the control groups, right? And so if you're having a patient that did both of them, I feel like that would be a really ideal, like, okay, what did you really think about this one compared to this one? But also too, the outcomes, I feel like if I am choosing a donor, I feel like minimal stimulation and donor shouldn't really mix, right? Because if you're using an egg donor, you want to get a lot of eggs at a lot of opportunities of pregnancies or of embryos, because very few of those will ultimately become embryos. So, there's of course different types of egg donation. Patients, is it an end cycle? Is it someone that's splitting it 2 or 3 ways? Or are you just buying 6 eggs from this one donor? Of course, that might be a different scenario if you're just getting a few eggs from one patient. But that's a question I have too. If it's a program in which they're splitting it between 2 and 3 recipients or intended parents, I probably wouldn't want someone who's having a minimal stimulation and also using in vitro matured oocytes, which are not necessarily as comparable to just the conventional simulation. So just a lot of questions I have. Again, I'm not trying to discount. I want our patients to have a pleasant experience, minimal side effects, but I would even argue too that our patients that undergo egg retrievals, they do well. Like I said, they're tough. These patients are very driven, they're very motivated, and we have the very nice technology of medication to help these patients feel good after the procedure. And I feel like a lot of them do really well. So that's just my thought. I just had a lot of questions as we were going through this. So
yeah, I have similar questions. Another thing I was thinking of, this is a nice N, but it's not large enough to capture the full range of complications in IVF. So yeah, we're avoiding really complicated OHSS cases with this, which are pretty few and far between in the age of Lupron trigger. But I worry that the actual procedure to retrieve these immature eggs is a higher risk procedure. So putting a needle into access these very small follicles is a more challenging procedure than enlarged follicles. And the other thing I was thinking about is that they said that they frequently removed the needle to flush it out. So there's multiple puncture sites each ovary, whereas in a good case, you can just have one puncture site on each ovary. And so that's really going to increase the patient's bleeding risk. And that because complications after IVF egg retrievals are pretty rare, we just don't have the N to really assess that complication rate. So are you trading, are we potentially, we don't have any evidence of this, am I potentially trading this lower OHSS risk for a higher rate of bleeding type complications afterwards? And then I'm like, well, if my ovary got stuck with a needle that many times, it might hurt a little bit more. Although, the symptom data data makes it seem like it didn't really, which is definitely interesting. So I think I would just want to see more information about the complication rate. Regardless, I agree, this is great technology, and I'm so glad this is advancing. This will be so important for some oncofertility patients, for some incredibly high OHSS risk patients. I'm so glad that we have this technology and glad we have this option.
Yeah,
Yeah.
absolutely.
I think you guys both raised really important points, and it really like practical points, points that like an REI has actually been in the room would know that maybe the scientists who are designing and conceiving of the rationale and providing the evidence maybe don't see. And yeah, I mean, just echoing that, I think that, well, first I will say that this is at the point of the spear, right? Bleeding edge tech, and I think underscored by the fact here that you have to kind of do these studies separately. The fact that we have just a field study here, and then separately in HR, we have the efficacy study. And then later on, we're going to have to do something where we actually see what the outcomes are in terms of live birth. Although you got to cobble together a strong base there in order to justify, as you alluded to there may be known and unknown risks to that patient cohort. So that said, I just want to say that it's an incremental thing. We got to do these things slowly, and I think this group is doing it slowly and carefully. But I do really need to see more data and more endpoints here, and have it be in a larger N, as you were saying, and from start to finish. Because you got to wonder, like, especially in some of these groups, like you take social egg freezers, for example, like, is it going to be 10 years? 20 years before they know whether or not, these eggs that they've had frozen with the min stim, it may have been convenient. They may have been very satisfied with the procedure, but are they going to be very satisfied with the embryo formation and development? Maybe not. And I think we need to know because Blake, as you were saying, like at the end of the day, these patients are willing to undergo the trauma if the outcome is there. And I think that them having a good time is much less important than them having their family. So I agree with you guys on all counts. We got to see a lot more data here, but certainly a step in a positive direction. And I think that's what's great about the science and F&S science, is that it's stuff that may not be here tomorrow, but it gives a window into what's to come.
The paper kind of makes me think of every now and then you have a patient who shows up in clinic, you do an IVF consult, and they say, great, so we'll go get the eggs today. You're like, oh no, this is actually like a 2-3 month thing. And
yeah,
so
let's go right now.
this sure is appealing, looking at the just 4 days of injections, you go to your retrieval. I can see that it would definitely be appealing to some patients. So
the new spa weekend, you have a stim weekend.
Stim weekend. Good to go.
And one thing too, I was curious about, and I admittedly didn't look back at all the references when they were talking about how OHSS is still present, although to a minimal degree in patients with PCOS, and they're saying it's reduced in patients with minimal stimulation. I'm just curious if those studies that still report OHSS, is this like a dual trigger where they're still getting a little bit of HCG trigger, in which of course the OHSS risk is going to be higher than just a Lupron only, but really, if you're doing a Lupron only trigger and a donor, especially, the risk of OHSS is so small. So I'm just curious about that. And these patients where they're quoting OHSS still occurred and kind of making it overinflated almost, were these dual triggers was my question. So I'd have to go back and look at that.
Yeah, and are they all only counting OHSS cases that warrant a visit to the ED or admission?
Right.
Or are they talking about like a very mild case of OHSS where the patients are just really symptomatic, which we do still see with Lupron triggers, and we'll take them out of work for quite a few days, but may not be life-threatening as it was more historically. So
a lot of questions for Gamito. Christian, we're going to give you a call.
Well, we should have brought him on. So last, but hopefully not least, my article from F&S Reports this month is called The Impact of Demographic and Clinical Factors on Elagolix plus Add-Back Therapy Effects on Patient-Reported Non-Bleeding Symptoms in Women with Heavy Menstrual Bleeding and Uterine Fibroids, a post-hoc analysis of data from 2 clinical trials. And it's by first author Jane Simon and last author Michael Snaves. So mine also is focusing on patient-centered outcomes and the symptom relief that this medication therapy is giving patients. So as we all know in this group, especially uterine fibroids have significant symptoms with significant impacts on quality of life. One of the most significant symptoms affecting both quality of life as well as bearing significant morbidity is heavy and prolonged bleeding and resulting iron deficiency anemia. And multiple different treatments are available for the treatment of abnormal bleeding associated with uterine fibroids, all with varying success and really varying success per patient. And this study specifically investigates whether elagolix can be utilized for this purpose and how useful it is. So I think we're all becoming a little more familiar with elagolix and similar medications in our practice. Elagolix, how are you guys pronouncing it?
I try not to say anything.
I'm an elagolix type of person, but a lot of
Great.
how I
That sounds better. I'm going to switch to elagolix for the rest
Yeah.
of the podcast. Perfect.
I don't know if you want to take an Oklahoma's phonetics for just take it with a grain of salt.
Okay, y'all, let's talk about elagolix.
Yeah, come on, y'all.
Elagolix is a gonadotropin releasing hormone antagonist, and what makes it unique is that it's also orally administered. So antagonists can also be preferred to using agonists like leuprolide because they avoid the flare effect that leuprolide can have. And there's also some data on utilizing oral GnRH antagonists instead of injectable during IVF stimulation, and I've seen some interesting studies there. Blake, have you been using elagolix much in your practice for any of its many potential indications? That sounded like a commercial. I'm not getting paid by the company.
Yeah. Full disclosure. Honestly, not really. It's I found that it's not covered by insurance a lot in Oklahoma, and if patients are paying out of pocket, it's really expensive. So I certainly would like to use it more, but I admittedly have not been using it a lot. How about you?
Yeah, I haven't used it much. It sort of came out when I was chief year of residency, and then most of our clinic patients were Medicaid, and so I really had trouble getting coverage for it. I think in terms of if we're comparing it to GnRH antagonist injectables that we're using during IVF, I think the costs are a little bit more comparable where you're paying out of pocket regardless, and it's always expensive. But I think for these indications of bleeding and fibroids, we have a ways to go before it's adequately covered for us to use routinely. So this study uses data from 2 phase 3 double-blind RCTs, Alaris UF1 and 2, and they looked at the amount of menstrual blood loss compared to placebo for patients on elagolix with add-back therapy. So they were looking at this quantitative, objective outcome of menstrual blood loss. The results from that trial showed that twice daily elagolix 300 milligrams with add-back hormonal therapy significantly reduced heavy menstrual bleeding compared to placebo, and it supported its approval for this indication in premenopausal women. These studies had this really objective measure of menstrual blood loss, and later secondary analyses found that specifically for women with uterine fibroids, including those with coexisting adenomyosis, the medication regimen also reduced heavy menstrual bleeding. So in the subset of fibroid patients, it was also useful. I think the objective measure of blood loss is totally important. That's a great starting point to get approval. But I wonder how much it really matters if it's not an improvement for the patient. So, for example, a patient's blood loss might be reduced by 50%, which was one of the endpoints in the original Alaris studies. But if they aren't actually noticing much of an improvement in symptoms, or they're still bleeding a lot, or they're still using, okay, I'm using 10 tampons instead of 20 tampons, this is still too much, and they're still needing to go for iron infusions, then how meaningful is that really for them? So this study was a secondary analysis looking at both non-bleeding and bleeding symptoms reported by the patients on the Patient Global Impression of Change scale. Have you guys heard of a Patient Global Impression of Change scale before, or have you used it in research?
I cannot say that I have.
I don't pay attention to the patient's feelings.
Your patients are mostly mice, right? So I haven't myself, but it seems like it's basically a Likert style scale. And what's unique is that it's evaluating how the patient perceives their clinical condition has changed over time. And so you ask, how has this particular symptom changed from baseline? And the responses will range from one being the very best, which is very much improved, all the way to 7, which is the worst, which is very much worse. So what did they find? So they had 591 women in the study, 395 received the elagolix and add-back therapy, and 196 received placebo. The mean ages of the patients were about 42. 67% of the patients were Black or African American, and the mean BMI is 33. So it represents really well the population of patients that are really negatively affected, specifically by fibroids and heavy menstrual bleeding. They looked at meaningful improvement, which they defined by choosing either very much improved or much improved. So the highest or second highest, score 1 or 2 on that PGIC response scale. And the response at 6 months of treatment was definitely positive in the study. So They also looked at these bulk symptoms, these non-bleeding symptoms. They found that abdominal and pelvic pain improved in 73% of patients getting the elagolix and add-back, compared to 21.6% in the placebo group. They had pretty similar results for abdominal and pelvic pressure and clamping, and they had a more modest response for back pain and abdominal bloating, which I think are a little bit more vague symptoms, with about 57% in improved and about 21% in the placebo groups in improved for back pain and 15% for abdominal bloating. And I think the really most impressive improvement was in menstrual bleeding, which makes sense. That was the primary outcome of the initial studies. And they found that 87.2% noted improved menstrual bleeding in the treatment group, compared to 22.9% in the placebo group. So those objective findings were supported by the subjective data, which is great. And many of these symptoms didn't take a full 6 months, so you didn't have to wait till that 6-month time point. They were actually asking the patients monthly, and they found that some of them improved at 1 month, 2 months, 3 months. So there was a faster improvement depending what the symptom was. So I think really promising data. Some caveats I have with the study were, of course, risk of bias. It is an industry-funded study from what I can see. And we also don't see the drop-off rate or dropout rate in this post-hoc analysis. We only see this really impressively high proportion of patients who are extremely happy with their treatment, 1 to 2 out of a scale of 1 to 7. But I'm curious, okay, so there's 20 to 30% for each of those questions that say, hey, it didn't really help. Were those patients rating it in the middle, or were they actually rating it a 7? So was it the same, no difference, or was it actually making things worse for some patients? And I could imagine some patients a combination of estrase and norethindrone every day. They may have a lot of breakthrough bleeding with that, whereas others might be really well controlled. And then I looked back at the original UF1 and 2 RCTs, and it did look like their dropout rate was around 20 to 25%. And so there are probably 20 to 25% of patients initially who were rating it 4, 5, 6, 7 on that scale, and we're going to stop the use because they were so miserable on it. And so even including those patients, I think we're still getting a really pretty overall positive response to this treatment. But I just want to be very aware that there's more patients we're not seeing who have left the study by that 6-month point. We also don't have results that are compared to one of our other mainstay treatments. So OCPs, leuprolide, levonorgestrel IUD, we only compared to placebo in this study. So in my actual practice, I'm thinking about a lot of different factors when I'm managing heavy bleeding and other symptoms related to fibroid. And I'm also thinking about the cost of the treatment, which we were talking about, and then the number of pills my patient has to take a day. So IUD, if it's not too distorted of a cavity, you can place an IUD, no pills at all, OCPs, 1 pill a day. This regimen could theoretically end up in 4 pills a day, so 2 elagolix, an estrase, and a norethindrone. It looks like they've marketed a pill, but it kind of has all in one, and you just take 2 pills a day, but I imagine that's pretty expensive. And although while these options can definitely help with bleeding, it is true that only your GnRH agonist and antagonist can pretty reliably shrink the fibroids and actually more reliably improve those bulk symptoms that are really plaguing these patients. So I'm definitely interested in this as a treatment option. It's going to be better than a lot of my other options for those bulk symptoms. And I do think this is very promising. And on that note, I think another cool study would be some fibroid volume studies. I'll have to see if that's been done at all with elagolix, and to really support, okay, bulk symptoms are improving and the fibroids shrunk 25% or 45%. And maybe that's coming down the pipeline if it hasn't already been done. But I think the option for elagolix with add-back really does expand our armamentarium for non-surgical options for fibroid management and heavy menstrual bleeding management, which is always great. And you're really not risking those bone density issues of using an antagonist or agonist alone. So what did you guys think of the study? And are you going to be using elagolix routinely now to manage fibroids?
Well, God knows I'm not doing anything like that, but I would ask you guys, how do you take something like this and incorporate it into your practice, right? As you were saying, I love that the primary study where it had the objective measure, and as you were alluding to, a follow-up would be great, something objective like the fibroid volume. I mean, the feels element of this, as a whatever basic scientist and being snooty, I would say, oh well, I mean, just the very much worse as a category to check. My 8th grade English teacher would have failed me on that, putting those 3 words next to each other. I don't even know if that's a real thing. But to ask you guys, when you hear it, let's say that it's like, okay, ironclad, it's real, there's a benefit. Do you like get the practice together and decide a consensus? Do you make the decision yourself? Do you give the information, share the information with the patient and give them some agency? I'm sure there's all different ways to do it, but like how would you, let's say that you were completely convinced, do you just change your approach to treating your patients like that, or is it case by case?
I've noticed, just through my fellowship, I've changed what's been my first line. When the data is not super clear or super supportive, I'll say, oh, I used to always pick this OCP. Now I always pick this one as first line. So I think it could be a fast thing. Suddenly everyone gets elagolix up front, or it could be kind of for select patients, I'm choosing it, or slowly over time, I'm transitioning to that being my first line. It's kind of how I would change my practice.
Got it. Yeah, I take this study. It is helpful. It's nice to know that there is this option. But me personally, and I would imagine a lot of other clinicians too, there would have the hurdle of cost and accessibility and insurance coverage, right? So I think it's nice to know that this is an option, but if this particular treatment is not being compared to, like Molly, as you said, like things that we commonly do, IUD, OCPs, or just Lupron even, if this is, that's a study I would like to see. Is this compared to those commonly used treatments? And what is the outcome? Is bleeding improved? Are these patients' symptoms improved when you compare the two? So that's what I would like to see, but it is reassuring. It's nice to know that there is another treatment that we can utilize for this. And then Molly, I was trying to do a brief search. There are studies that have looked at elagolix in volume. I know that there's some in the journal, or like a minimally invasive journal, and they say that there's not really much change in terms of volume. I'm blanking on the author's name, and so I know I'm hanging my dirty laundry out to dry on this podcast, showing that I don't sound very smart, but I know that there was an article, maintenance of certification article, that had looked at that too, showing that there is some minimal improvement in some of the larger fibroids too when using elagolix. So some of those are out there, but again, comparing them to when you're looking at this specific topic about the patient outcome and their experience and bleeding symptoms, I would like to have that compared to the more commonly utilized treatments. And I think that would be really helpful. That's just me personally, though.
Daylon's patient from before that had the severe needle phobia example, this would be a great option because we're not going to use Leuprolide for her. So here we go, elagolix. So, well, thank you all for joining me today, and thanks to all our listeners for tuning in. And we're looking forward to talking to you next month on F&S Unplugged, and we'll have Pietro back then with his melodious voice as well. See you guys later.
Thanks, everyone.
This concludes our episode of Fertility and Sterility on Air, brought to you by Fertility and Sterility in conjunction with the American Society for Reproductive Medicine. This podcast is produced by Dr. Molly Cornfield and Dr. Adriana Wong. This podcast was developed by Fertility and Sterility and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While the podcast reflects the views of the authors and the hosts, it is not intended to be the only approved standard of practice or to direct an exclusive course of treatment. The opinions expressed are those of the discussants and do not reflect Fertility and Sterility or the American Society for Reproductive Medicine.